Today, inshallah, my presentation is going to be about sequential segmental analysis of the heart. So, content of this lecture gonna be about atrial arrangement, atrioventricular junction, and topological arrangement of the ventricular mass, ventriculoarterial junctions. So, in the beginning of sequential segmental analysis, heart should be divided into three segments: atrial segments, ventricular segments, and arterial segments, and two connections connecting these segments to each other. We have the AV junction, atrioventricular connection, and ventriculoarterial junction. So the morphology of atrial appendage that provide the most reliable feature for atrial recognition, and apical trabeculation is the most useful for distinguishing between the ventricles. We have two morphological types of atrium, right and left. Usually right atrium is triangular in shape. The appendage, right atrial appendage is triangular in shape, while the left atrium appendage is more tubular. For the atrial arrangement, as we said, we have right morphological, which is triangular in shape, with the pectinate muscle extends all around the atrioventricular junction to the back of the heart. As we can see here, the pectinate muscle character, while the left atrium has a tubular appendage with a narrow junction, mainly pectinate muscle being confined with the tubular appendage. So triangular appendage, regarding the arrangement, if the triangular appendage is in the right side and tubular appendage is the left side, as can be shown here in the picture, the usual arrangement is frequently called situs solitus. This is the usual arrangement. Now coming for the secondary arrangement, which is called mirror image, when we have the left tubular appendage on the right side, morphological left, on the right side, and the triangular appendage on the left side is called mirror image or situs inversus.
Situs
Inversus, sorry. Appendages can be either be both triangular or tubular. This describes isomerism of the right or the left appendage. Typically have jumbled abdominal organs along with isomeric arrangement of lungs and bronchial tree. The overall arrangement is called visceral heterotaxy. As you can see here, we have both left tubular atrial appendages and right triangular appendage on both sides. So some characteristic of isomerisms. In case if you have a right isomerism, the sinus node will be duplicated. This can be shown here in picture B. While in setting of left isomerism, the SA node will be either absent or hypoplastic. Now for the lung arrangement and abdominal organ, A, which shows the normal, usually you have trilobe right lung, bilobe left lung, and the liver subdiaphragm in the right side, spleen in the left side. In case of mirror image, we have the reverse. We have a bilobe right lung, trilobe left lung, and liver being confined on the left side, spleen on the right. In right isomerism, we have both bilateral triangular trilobe lungs, liver being centrally with a splenia, absence of the spleen. In left isomerism, we have bilateral bilobe lungs, central spleen with central liver with polysplenia, more than one spleen. For bronchial tree and pulmonary artery, normally we have the right and left pulmonary artery being anterior to the right and left, being anterior to the right main bronchus, and superior to the left bronchus with the long left main bronchus. In case of right isomerism, both pulmonary arteries are anterior to the right and left bronchus with a short left main bronchus. In case of the left isomerism, we have this right pulmonary artery being superior to the right bronchus. So, in case of our right isomerism, also we have resistance superior vena cava on both sides. Now, for the feature, main feature for right isomerism, we have bilateral morphological right atria, asplenia, bilateral trilobe lungs, symmetrical liver, and total anomalous pulmonary venous return. While left, we have bilateral left atria, bilateral bilobe lungs, interrupted inferior vena cava, and partial anomalous pulmonary venous return. These are the features summarizing the whole feature of right and left with visceral heterotaxy. I will not go through it, just for the review later on. Now coming for the next, for the atrioventricular junctions. Regarding the atrioventricular junction, has two patterns, either concordant or discordant. Concordant happens when there is a right atrium connected to the right ventricle and left atrium connected to the left ventricle. Also concordant can be in mirror image when the left atrium connected to the left ventricle and the right atrium to the right ventricle. Discordant happens in the reverse when the right atrium connected to the left ventricle and the left atrium connected to the right ventricle. The appendages being isomeric, then irrespective of arrangement of the ventricle, atrioventricular junction connection are biventricular but ambiguous. For the topological arrangement of the ventricular mass, theoretically, if the hand of the observer, right hand of the observer, placed on the septal surface of the ventricle with the thumb pointed to the inlet and the wrist pointed to the apex of the heart, while the fingers pointed to the outlet, is called right hand ventricular topology. On the left, if the left hand of the observer pointed, the thumb pointed to the inlet, the fingers pointed to the outlet, and the wrist pointed to the apex, called left-handed ventricular topology. Just reading what we said, the right-handed topology, palmar surface of the right hand of the observer that can be placed on the septal surface of the ventricle with the thumb in the inlet, the wrist in the apex, and the fingers in the outlet. Left-handed topology, palmar surface of the left hand of the observer can be placed in the septal surface of the ventricle with the thumb in the inlet, the wrist in the apex, and the fingers in the outlet. Either of these two arrangements can be found when the hearts with isomeric atrial appendage have biventricular atrioventricular connections. Second group of the hearts that do not exhibit biventricular atrioventricular connections, the atria are joined to only one ventricle, thus the heart have univentricular atrioventricular connection. All variants can exist, irrespective of whether the atrial appendage are lateralized or isomeric. The junctional morphologies making up the group are double inlet ventricle and abscess either of right or the left atrioventricular connection. Atria can be connected to a dominant left ventricle, a dominant or a dominant right ventricle, or a solitary and intermediate ventricle. When the atria are connected to either a dominant right or left ventricle, the complementary ventricle is incomplete and hypoplastic. Incomplete right ventricle, as found with atria, are connected to a dominant left ventricle and are always positioned anterior superiorly relative to the ventricular mass, although they may be either right side or left side. Incomplete left ventricle as seen in the presence of a univentricular connection to a dominant right ventricle are always positioned posterior inferiorly, but again might be either right or left side. The feature of solitary and intermediate ventricle is that they do not possess a second ventricle. This diagram summarizes the arrangement of atrioventricular junction. So we have here the usual arrangement: morphological right triangular on the right side and left tubular on the left side. We have the isomerism right and left. We have the mirror image. Now the connection with ventricle either be double outlet, double inlet ventricle with two valves, or univentricular connection with being the left ventricle dominant with the hypoplastic right ventricle, or absence of the connection of the left ventricle with a dominant right ventricle. Regarding the ventricles, in case of double inlet, can be intermediate, can be a dominant left ventricle or a dominant right ventricle. Again, the same picture. Usually the hypoplastic right ventricle lies anterior superiorly to the left ventricle and connected to the dominant left ventricle, while in left ventricle lies posterior inferior and connected to a dominant right ventricle. The arrangement of the atrioventricular valves depends on the number of atrioventricular junction. The dual atrioventricular junction, however, can be guarded by two separate valves or by a common atrioventricular valve. One of the two valves, are rarely both, may straddle the ventricular septum when the tension apparatus attached on both sides of the septum. The overriding valve is assigned to the ventricle connected to its greater part. Common valve usually straddle, but not always. Common valve guards two atrioventricular junctions. This picture showing the types of valve. In case of straddling valve, we have the chordate tendinate across the VSD and attached to the opposite ventricle. Overriding, which is in case the annulus crosses the VSD and lies over more than one ventricle. Now coming for ventricular-arterial junction. In the analyzing of ventricular-arterial junction, it's necessary to distinguish between specific junctional morphology and the structure of the atrial valve or valve guarding the, between the arterial valve or valves guarding the junction, arterial relationship, as well as the morphology of the ventricular outflow tracts called infundibular or conal anatomy. Again, they have two patterns as the atrioventricular junction. We have concordant and discordant. Concordant when there is when the pulmonary trunks connected to the RV and the aortic artery connected to the LV. Discordant when we have the aortic artery connected to the RV and pulmonary trunk connected to the LV. Other types, which double outlet, exist when the larger part of both ventricular arterial junction take origin from the same ventricle, which can be right, left, or solitary and intermediate morphology. As shown here, both pulmonary trunk and aortic artery are taking origin from the RV. Single outlet from the heart describe the situation which only one patent arterial trunk can be traced from ventricular mass, either can be aortic or pulmonary. Which shown here in case of aortic atresia, we have one only pulmonary trunk which is connected to the RV, and in case pulmonary atresia we have only one arterial trunk connected to the ventricle. Other types, we have common trunk and solitary trunk. Common trunk we have when we have one great vessel originating from the base of the heart, supplying the systemic circulation, coronaries, and the pulmonary arteries. Solitary trunk, when we have one great vessel, which is in this picture, the aorta, supplies the coronary and systemic circulation in the absence of main pulmonary or branches of the pulmonary artery. This is my end of presentation. Any question?
Thank you very much دكتور عبد الله. أنا أعرف إن يعني الموضوع هذا is complex صراحة، مفترض إنه ما يقدمه juniors, but you did a very good job. يعني I don't know if I can do it better. وفي أشياء كثيرة أنت تكلمت عنها I just understood it يعني understood it recently. Thank you very much. وإن شاء الله السنة القادمة راح نحاول نقسم محاضرات حسب الليفلز، يعني like categories مثلا R1 R2 the level of lectures will be different than R3 R4 and most complex lectures will be for R5 R6. Thank you very much. I think you covered almost يعني everything. I have one question. يمكن دكتور فريد أو واحد من السينيورز الآن what's the difference between right-handed topography, right-handed and left-handed topography and dextrocardia and levocardia? Is it the same or not? يعني الآن اللي أنت قلته قبل شوي you talked about the mass of the ventricles or just the orientation of the apex.
What I read is usually dextrocardia or left hand, the position of the apex. I'm not sure if Dr. Farid can elaborate more about.
So yes, it is the same, but it's now to understand other connections and other problems, it's better to use the left and right hand topography. But otherwise, it's the same. You may find additional pathology. When we say dextrocardia, routinely, we assume that all the intracardiac structures are normal.
Mm-hmm.
But it may not be. And if it's not, it's better to go with this configuration, the topography arrangement. That will give you more of a clue if the patient have transposition or if the patient have double inlet, double outlet ventricles, and so on and so forth. Interesting, very good, concise presentation. I mean, I'm Abdullah is the presenter?
I know.
Okay. It's an excellent summarization. Really, it's a very nice summary for a very complex topic. And I don't think anybody need to know more than what you have already presented in those few slides. I know the reference of these drawings, and I think every one of you should really have it. Do you know the author of this chapter?
I'm not sure. I don't know.
Okay. This is the same one I'm telling you about. I just announced it in the beginning of the meeting. He will be presenting on Friday, tomorrow. I'm not sure of the time, but I just sent the link again. It will be, it's called, I think, the Congenital Heart Academy. It's a group of more than 300 people are enjoying this academy. It's placed in Italy, Rome, Italy, and the time is 3 o'clock in the afternoon by Italy time. So it's probably around 2 o'clock in our time. I'm not really sure though. Dr. Robertson will be the one who is presenting the AV valve abnormality, and he will be giving series of lectures in the anatomy of the heart. He have elaborated in many chapters. For example, the chapter in Kirkland is also written by him. Many books that have anything related to the structure, configuration of the heart, he have contributed a lot. There is another famous person also, not as famous as this Robertson, but it's I forgot the name. I think it's Clark. Based in both of them. Sorry, this one is from England. Mr. Clark, I think his name is. And he has also quite a bit of reports and participation in anatomy of the heart. Not yet. Okay, stop here, please. Okay, stop there. What's wrong with those two pictures, Murtada?
There should be in the aortic atresia, there should be atretic aorta. It shouldn't be like this.
Okay, but it may be atretic to the point that we cannot see it, but that's okay.
And then the second one is it has the same problem. If there is a pulmonary atresia, it means atresia, not a complete absence. So
okay,
there should be like an atretic result.
Okay, but with an atresia, it could be very minuscule. It could be not seen at all. It is a possibility. But look at the picture on the right and tell me the blood is coming now from the right atrium to the right ventricle, right?
Yes.
How is it leaving the...
There should be a connection.
Okay, what kind of connection we're talking about?
There should be an intracardiac shunt to shunt the blood from the right side to the left side.
And where's that shunt?
Here, I think it's an ASD covered by the aorta.
If it's an ASD, it's different from VSD. It could be either ASD or could be VSD. It can be either. But if it's an ASD, what will happen to the right ventricle?
If it's an ASD, what will happen to the right ventricle? It will be atretic or hypoplastic, because it will not be subjected to a systemic pressure or high pressure.
And if it's a VSD, it may have a normal anatomy like it's shown in the picture here on the right side. And the same applies, by the way, to the left side. So you have to have an ASD or a VSD, one of them. If it's an ASD, the left ventricle will be hypoplastic, or if it's a VSD, it may have a normal size VSD. Normal size left ventricle. Okay, nice, nice. What do you call that? Deep thinking, Murtada. Go now backward a little bit, please, on the slides. More, go toward the, let me just see it. Further, please. More. Okay, stop here. Come back to the, okay, here, yes. What's the significance, and this is to the junior guy, maybe Abdullah, you can start with the answer, of the right-sided heterotaxia, right isomerism heterotaxia. What's the significance of this disease?
Have right side have
so the one on the
thoracoabdominal.
you go to the left, lower left. So lower left, you can put your pointer there, please. Yes, this is the one. So what's the significance of this disease?
Mainly we have here absence of spleen, which
what does that translate into?
Increasing risk of infection and
correct, and that's something we have to pay attention to when we operate on those patients. We do offer them surgery, but in general, heterotaxia has a major concern. Murtada, can you answer that, or any of the senior?
Like a technical challenge, you mean, though?
Well, there's, okay, in the outcome of those heterotaxia, we have a major concern. The major concern is that they have higher mortality and morbidity. And if they do have heterotaxia along with major complexity of the heart and asplenia, many surgeons, many heart centers will shy away from operating on those patients because the outcome, long-term outcome, is very poor. Be it Fontan or be it whatever procedure you're going to do for them. And we usually counsel those families regarding the potential complications and poor outcome they will have. Okay, those are the two messages that I wanted to pass on. So from this presentation, it's a very nice detailed presentation. It's very good to understand, especially the isomerism issue and the situs solitus or situs inversus for you to know, because those are usually intriguing questions in X-ray presentation, or they may show an X-ray, or they may ask you about the exact anatomy of the bronchus, for example. But the clinical application of those pathologies is the association of certain orientation of the heart with certain diseases and the outcome of those diseases. Okay, that's all I had to add. Thank you very much, Abdullah.
You're welcome, sir.
عبد
تفضلي.
معلش آخر سلايد. Yeah, I didn't get this slide. Can you repeat it, please?
Okay. There are different types, single